there's that opening slide where it says, I'll show that in a second here. Text to 443-541-5052, the code 29865. We've got 3 panelists that will be discussing the topics with us today, and I'll have each of them introduce themselves. So Ty, could you say a little bit about yourself?
Sure. Well, good afternoon, everyone. I'm Ty Crow, member of the Ethics Committee here at Johns Hopkins Hospital, and I'm also Director of Spiritual Care and Chaplaincy here at JHH.
April?
Hi, I'm April Sharp. I'm a pediatric neurology fellow at Kennedy Krieger and here at Hopkins, and I'm also a member of the Hospital Ethics Committee.
And Shirley?
Hi, I'm Shirley Rawson. I'm a community member of the Ethics Committee here at Johns Hopkins Hospital, and that's it.
Okay, great. So let me show you what we're going to be doing today. We're going to think about the past year in terms of the relationships that we have in the clinical encounter, how we work with patients and families, particularly after the death of George Floyd and of the events that have transpired over the past year, greater attention to the aspects of justice, especially in working with diverse members of our community. Really thinking about for the pandemic, for COVID, for other aspects of care where there may be life and death decisions being made. How do we work with patients and families to discuss those things? And then, as I said, we'll use some time at the end to address any ethical issues that you think the hospital community should be addressing. So we had a lot of topics over the past year. I'm going to run through each of those, and we're going to use polling today as a way to engage with you, the audience, get your reactions to these topic areas. So it included hospital visitation, disclosure to pediatric patients, the allocation of the COVID vaccine, working between the faith community and racial and ethnic minorities when they face ethical dilemmas, thinking about pain management for patients with substance use disorder and having severe pain, thinking about the many ways that trust was challenged during the pandemic, especially for non-pandemic times, thinking about the issue of brain death and how to work with families when there's been a devastating neurologic injury. Our Schallenberg lecture over the past year was Joanne Braxton talking about the outrage of Black mothers. And then lastly, last month, we talked about the 21st Century Cures Act. So we'll try to cover all of those in the next 55 minutes or so. For those that are unfamiliar with how Zoom polling works, you should be able to find that either at the bottom or the top of your screen, and you'll see the question. I'll bring it up, and then you vote, and then we will see a tally of the votes from the audience. Okay, so I'm going to see if I am successful in doing this. So here's the first question. How many Ethics for Lunch sessions have you been to in the past academic year? Okay, I think you can now see the results. So good percentage of you, over a third, have been to more than 5 sessions, so regular attendees. Thank you for that. We've got a couple of folks that are new to Ethics for Lunch, and then a smattering of other choices in there. So next one, I'm gonna see if I can find that. Suzanne, how do I get to the next question? There it is. All right. Now this one, what is your role? And I may not have been all inclusive for the various things that people do, but if you could specify what you do here at Hopkins, or if you're a member of the community. And if there's an other category, feel free to put that into the chat. Just like to know who our audience is. Okay, we're getting pretty close to a quorum. When I get over 2/3 of the votes, then I will end the polling. And we've got a good representation by chaplains today, and then a few other folks, other things represented. We have a child life specialist. We have an undergrad intern. So great, welcome everyone. All right. So now we'll go on to the next topic, our first topic of the year last September, and it was dealing with hospital visitation during the pandemic, and the issues of protecting the public health, trying to decrease the chances of getting exposure to COVID, but also trying to help patients as they are dealing with their illness in the hospital and having access to their family. So here's the next question in the polling. All right. In retrospect, should Johns Hopkins have allowed more visitation during the pandemic? So almost a even split, but people, at least the 56% favored no, we shouldn't have done things, shouldn't have allowed more visitation. Any of our panelists want to comment on this aspect, since it was a source of a lot of moral distress on the part of healthcare team members, knowing that families couldn't visit.
Well, I can chime in just briefly, Mark. And this is not a topic that's even completed yet, right? We're still not returned to a place of the way we were functioning back in 2019. But the stress involved, and in particular, I think with the physicians in our MICU and other places where you're caring for patients who have COVID, who are not able to communicate, and we don't have family members. I mean, that was a consistent source of like major stress. A place where you could normally get some information about who this person is, and it just wasn't there. And I think that was really highlighted in with our patients that couldn't communicate for whatever reason. And then it was just an ongoing back and forth. Interesting that the poll today was so even, that we recognize the stress involved connected to the medical care team and what typically we get to interact with a family member or a visitor. And in that case of them not being present, what was, and what I think even in some regards still is, points of stress along the way. I mean, I think it's more significant than we realized. Of course, we have to keep safe. Of course, I mean, it was back and forth. In fact, I remember being present in this. It felt like I was on the jury. I don't know how other people felt when during that ethics for lunch, but I felt like we were hearing two arguments and listening into both sides very evenly, making a case that both of these situations are causing stress.
There's a comment in the chat of, and I think that was pertaining to this question of whether it might have been different in pediatrics. So Ty, you brought up the example of, patients unconscious or not able to communicate in the ICU. But there was also the situation of children in the children's center where there might be limitations in parents being able to visit, or obstetrics, another example where there might be visitor restrictions. April, do you want to say anything about sort of the pediatric situation?
Yeah, we were lucky in pediatrics that one parent was able to be there at all times, but additional family would have to trade out. And I think there was particular stress with, two parents or whatever a parent's support system is not being able to be here. They already have a sick child, some of which are hospitalized for weeks or months. And then also navigating switching out with family members or not having other loved ones here to support them through those difficult conversations and seeing their child so sick. And so I do feel that on the pediatric side, there was more of a feeling amongst caregivers and providers for how to get multiple parents, multiple family members in as soon as possible in of course, a safe way.
And then some of that onus of making exceptions to the rule was, on an administrator's side or members of the healthcare team having to advocate to get exceptions to the visitation. Shirley, any thoughts from a family perspective about this visitation issue in the pandemic?
Yes, since we experienced this pandemic, is there possible any way to increase a video contact so that parents who could not visit or parents who felt that it was that it was not safe for them to visit, to be able to interact with their children? Because even when you go on trips, you kind of interact with your children through FaceTime and different things. And that's how I interacted with mine through FaceTime during this entire year, because I've not seen them in person. And they weren't sick, but if my child was sick, I would at least want to be able for them to see that face.
So greater use of technology and at least being able to see a person's face or communicate with them, even if they couldn't be in the room.
That is true.
So as Ty said, we are still in the midst of this. So right now, I think we are in the yellow zone. So we're not fully open. We do still have some amount of visitor restrictions. And this, as this slide says from our website, that it's based on what the rates of community COVID cases are, and then as well as what the hospital conditions are. So that all gets factored into how we, as an institution, make decisions. And there are responsibilities, if you are a care partner or visitor coming to see a loved one, then the fact that you have to still adhere to social distancing and masking, staying in the room, etc. So we do want to still pay attention to not having further chance of transmission. There's a comment in the chat about then the fact that patients might be dying alone, and so while we do have visitor exceptions for end of life, this is all the tables that are used nowadays to determine these green, yellow, red, and purple zones. And then the bottom right-hand one, can't read it, but it says where there might be exceptions and end of life, which then has to be defined of is it imminently dying patients or patients that might have a few days of life, trying to prevent that real tragedy of patients dying alone.
Mark, I'll add that I think that, that this is still a topic and we may need to be addressing it even next year as well. I think that the experience of our healthcare team as a whole, we don't have an assessment yet of the memory, the stress. I think I don't even know what the word is exactly, to be honest. And I think that how we as an institution respond to what it will look like when we return back to green, for example, and we're on green for 6 months, then maybe we can look back and say, how are we doing and how did we do this? Because I think that taking an inventory of how we're feeling in retrospect to what we just endured is going to reveal more and more. For those folks that have, especially around the front lines, Nelson 5, for example, all those team members that have cared for folks on the front lines and have witnessed firsthand people dying by themselves over and over again. It's hard to put a finger on or to choose a word that best describes it. But I think it's important to underscore that it will be with us for a while. And I hope that it is, that we don't move on too quickly, because I think that would be a mistake.
Great, thank you. So our next topic area in October last year was, should children be told that they are sick or dying when their parents refuse? The parents say, we don't think the child should be told their prognosis or diagnosis. So here's the question for you all. When a child with advanced cancer asks a nurse about their prognosis and the parents have indicated they do not want their child to be told their prognosis, what should the nurse do next? Honestly inform the child about their prognosis, lie to the child and indicate the prognosis is better than it is. It depends on the age and developmental stage of the child. Ask the parents what they would be comfortable with the nurse telling the child. Contact Child Protective Services to report the parents are not acting in the child's best interests. Okay, so it looks to be an even split between a little more people favoring ask the parents what they would be comfortable with the nurse telling the child, or it depends on the age and developmental stage of the child. So, in pediatrics, we're dealing with all the way from infants to 17-year-olds. So that might make a difference in what gets shared, but then there's still the need to have a conversation with the parents. April, do you want to comment on this one?
Yeah, I think the ideal answer is some combination of the two that were chosen. Information sharing with children is always dependent upon their age and developmental stage and what they will be, what they're expected to be able to understand. And then adding the layer of complexity of what the parents want them to know can be really hard to navigate and when they want them to know it. Ideally, these are conversations that are all had up front. And so if a family says, we don't want our child to know this, or we don't want to tell them yet, having kind of frequent conversations, checking in and saying, this is what we are, where we are, this is what we know. This is what we are as a care team observing in your child. These are the questions we're getting. And sorry, there's a fly. And kind of exploring with them what they think their children understand or would want to know. Because very often children pick up on things, either from nonverbal language or because they know their bodies and what their bodies feel like when they're sick, etc. So just frequent communication with the families and helping them in their grieving process often helps resolve these situations over time.
Great. Yeah, so some preventive ethics in there, of, as you said, sort of upfront, having these conversations with parents to anticipate that the child may indeed ask questions if they know, something's going on with their body, or they sense, something going on with, their caregivers or with their parents. And And if they're going to ask questions, to really anticipate what those questions might be and what the parents would be comfortable in sharing with the child. So, when we had the ethics for lunch, it was this idea that parents do have, authority and autonomy to make decisions on behalf of their child and determining what's in their best interest. So it is this conversation that needs to be had with them about what they'd be comfortable with sharing. And avoiding, actually lying to the patient, which was one of the choices. Nobody picked that one. But really making sure that you can meet the child's needs, the parents' needs, and feel comfortable as a healthcare team member that you've served the child's best interests.
Mark, I would add that we don't always know why. And so that I think that checking in with the parents would be important and really hear some of their reasoning. There could be a cultural value that's emerging that we didn't know about, but it also likely is connected to how they feel. And if we can spend maybe a little more time checking in with mom and dad or whoever the caregivers are, and get a better sense of what's happening here and why withholding information. And then also maybe just asking something concrete around, well, when your child asks, assuming a 13-year-old may ask why they're in the hospital for a week, and the caregivers are not in the room, how would you wish us to respond? I think that again, just a check-in is really helpful.
Shirley, do you have any thoughts?
Yes, I do. Considering I have a lot of children. For most children, if they're dying and the parent says that they don't want them to know, I would go with that and let the parent shoulder the burden of calming the child down and expressing to them what diagnosis that they have and the possibility that they might or might not make it. And also during this pandemic, you probably didn't have a lot of parent in the room. I'm not sure if you did or not, with the children to let them know that there's a possibility that they won't make it, that their life will be shortened. But I think you should definitely leave it up to the parents whether or not they want their child, because it could cause more stress and more injury through stress of an illness that you have. So I would defer to the parents of what they would like to have their children know.
Okay, yeah, relying on their authority and
Yeah.
Knowing their child the best.
Yeah.
All right, so our next topic was the COVID vaccine. So back last fall, we were thinking about, how are we going to allocate this in a fair way to make sure that those either most at risk or those at risk of transmitting it to others would get the vaccine. How do we prioritize who would get it first, second, third, etc. So here are a couple of questions with regard to that. And nowadays we're in a different situation with the vaccine. So here's the question dealing with now. Apart from religious and health exceptions, should the COVID-19 vaccine be mandatory for healthcare workers? It's waiting for that one no to come in. I'm going to show you the results here.
Yes.
So it was going to be 100%, but then we had one person say no. I don't know if that person wants to say anything in the chat as to why they think it should not be mandatory, but pretty overwhelming percentage here of people think it should be mandatory. Any of our panelists want to comment?
Okay. You ready?
Yeah, please.
I believe it should be mandatory because you would not want to bring a sickness into a place that is full of sickness. They're in the hospital because they're sick. They're not there because they're healthy. And, you know, it behooves me just to go to the market and not knowing who has it and who does not have it. I did home delivery for at least 8 months until most of us were vaccinated, especially those who were more vulnerable to the disease, like elderly patients or elderly persons, and you know, felt that at least they were getting the vaccine first. And then we could venture out, maybe the younger ones would be healthier to avoid wear a mask, continue to wear that mask until we are totally out of it. But yes, I think it should be mandatory for healthcare workers because they go home to their children, they go home to their spouses, they go home to their family. And I think they should be.
So part of their obligation to protect the patients is not to bring the infection into the hospitals.
Correct.
I think another aspect of it is that patients trust that we are doing things that are in their best interest. That is why they come to the hospital or the clinic and seek our help. So part of that obligation is doing all of the things that we can that will be in their best interest, which means keeping them healthy and keeping ourselves healthy so that we can continue to provide that care.
Let me ask the next one. So hopefully we are getting, through this pandemic, but were we to have any uptick in cases in the future, how do you all feel about this? This was one of the discussion points in the Ethics for Lunch. So which of the following is more important in prioritizing COVID vaccination? Prioritizing those at highest risk of having morbidity or mortality from COVID, or prioritizing those at higher likelihood of transmitting the virus to others? So here, more people went with those that are having higher risk of morbidity and mortality. So we had certain populations, elderly, African American, people of color, communities of color, where we saw that they had higher morbidity and mortality as a result of this. And so, at least for this audience, prioritizing those people would be higher than those that were more likely to transmit it. There's a comment in the chat. See if any of the panelists want to react to it. Doesn't the public have the same moral obligation to keep healthcare workers safe in a pandemic? So do they have an obligation either to get vaccinated or reduce their risk of transmission or acquiring the infection by masking, etc.? Anybody want to react to either the poll or to that comment in the chat?
As a general response to the comment, one of the things that shifted in March of 2020 is thinking about ethics on an individual level to thinking about public health ethics. And that was a very new and at times difficult shift for people at all levels, for the public, for healthcare workers, for everyone else involved, and really everyone. And so I think one of the questions going forward is how to keep that sense of public health ethics as we get back to a place where we're functioning more with individual ethics again, or how those have interacted with each other over the past year. And it's been very interesting and certainly is not worked out by any means.
Well, I think in terms of the question around staying safe is something we've had to wrestle with, before the vaccine came out. And those of us who were parents are also managing children who needed to also understand on whatever level they were, how and why we are doing certain things, why, Shirley's not seeing her children, to explain that to a 16-year-old or a 9-year-old is what many of us have had to do, and sort of manage those relationships as well. And there's no right way to do it, I don't think, but certainly it forces everyone to look beyond themselves. And I think, as April said, this sort of system approach, this understanding of a public health approach has really forced us all, I think, to become less selfish, less self-centered, which is maybe not as natural to us as Americans, right? So I think this is on a national level, part of this tension that we see now. But that's to say, at least my hope for my own children is that they understand a little bit more about how what they do will impact somebody else. And that's a lesson I hope that they will take with them for the rest of their life.
Yeah.
I'll just show you what we thought about back then of how do we prioritize. So those essential in sustaining the ongoing response to the pandemic. So that included the frontline health workers, those at risk of severe illness and death, that's the morbidity and mortality aspect of this, and their caregivers, and then maintaining societal functions. So that's how we thought about prioritization early on in the pandemic. We had these different categories of, for occupations, whether you had a low risk of exposure or very high risk of exposure, as frontline healthcare workers would. So that might be a factor in now when we're thinking about vaccination in the world, how we might need to consider who's most at risk. And the reason I had the initial question about the mandatory vaccination is we just had in the news this past week, Houston Methodist, where some of their employees had objected to mandatory vaccination, and the court case was settled in favor of the hospital, saying they could require staff members to get vaccinated. And also in the past week, the Maryland Hospital Association and this letter from for the Johns Hopkins community, saying that in the next couple of months, by September, there will be an expectation of mandatory vaccination, with the exceptions of religious or health reasons, but otherwise expecting that people, if you're working in healthcare, supporting the mission of the hospital or health system, you will get vaccinated. Okay, so then the next topic area in December was the role of the faith community in working with racial and ethnic minorities facing ethical dilemmas. So here's the question for you all. Religious rituals should be foregone in a biocontainment unit. So if we're thinking about Nelson 5, our MPC unit that was biocontainment unit for much of the pandemic, people needing to have appropriate PPE, would there be a need to forego any of the religious rituals the patients might need at that time? So majority of people said no, we should still perform religious rituals. Ty, do you want to comment on this one?
Well, this was a question that strikes at the heart of our original questions as a department, really, for the hospital, is how are we as chaplains going to respond to what the needs are, and the needs are going to change, and certainly end of life. How are we going to attend to this, and how can we ensure that we are all protected so that we can show up and move in and move towards and not away. And I can just say I'm really proud of our team. I think that we did. We had to balance being safe with knowing that we were needed, and that was our goal. And I know that everyone worked very hard to be as attentive as we could to every need as we were aware of it. It did mean that we had to, take some risks early on, because there was a time there where we weren't sure exactly what PPE and how much, and was there enough for everyone, and so on and so forth. So we wanted to make sure that we were moving towards, but also still safe. And I do think the question of religious rituals, there may be some that would be optional. And I think if the question was really specific around like end of life, or something that was really a core central part of that patient's practice, that we be able to honor that. And in those cases, I'm obviously in favor of doing that.
Sure.
I was just going to say one more thing, that the piece around from the patient's perspective often is those who are very religious and or spiritual understand that everything that they experience is through the lens of their faith. And to move that away at the time of most stress, most intensity, it feels almost like a harm. So at any rate, understanding that is a significant part of healing, and it's a real and present need. Sorry, go ahead, Shirley.
I was waving to my husband. He's going to the store, but yes, I wanted to chip in on this. At the beginning, when it was at its unknown worst, how bad was this going to get? Churches all went to virtual. I attended Mass every Sunday, and the religious Mass went through Easter and all those other big Masses, Christmas. But you have to be careful. Everyone had to be careful, because this was almost an unknown moment that hadn't happened in 100 years, the Spanish flu. I read up on that big time. But the Spanish flu, of how we're going to make ourselves out of this without losing way too many. We lost way too many. I lost 2 sisters through COVID, and was unable to attend the funerals because of, you're not sure of what you're going to pick up or who's going to pick up what. But so I would go with true, that they should be foregone in a biocontainment unit. At the beginning of this, maybe instituted as we get further along and more people are vaccinated, and the disease has more or less diminished in the effectiveness of it.
So it's this risk and benefit of the risk of acquiring it versus the benefits of adhering to, the spiritual beliefs and seeing that as a part of the healing process. The comment in the chat is, not a yes or no, but a how, or how do we make reasonable accommodations to try to accomplish the goals of the religious ritual.
Yeah, one of the things I'll add to that, maybe to Shirley's point, is figuring out a way to so historically at Johns Hopkins Hospital, Ash Wednesday has been a pretty significant event for our Christian community employees mostly, but also patients. And one in which we really did accommodate. We had to make some major adjustments, and I think we were able to do that successfully, but with, lock and step with HEIC consultation, ways in which we could try to meet that need. But we still have yet to really resume regular religious services in our interfaith chapel, for example. We're still moving very slowly in that regard.
Have there been virtual opportunities for services similar to out in the community?
Well, one of the things that we didn't try to replicate as a department was because so many people were already doing that, that we didn't feel like we needed to replicate that, because actually one of the maybe a small silver lining is that the access to a religious service actually increased during time. So we actually look at people attending services increasing over this time, because they could so conveniently show up in their pajamas or to get on the video and listen to a service, listen to a sermon. It's not the same as being together, but certainly people were doing that more and more. So we didn't feel the need that we needed to try and replicate that just as a department.
Some of the points that were made in the Ethics for Lunch is, and goes to what you were saying, Ty, is that, for many patients, their faith community is an important aspect of their lives. And so having chaplains that can bridge that gap between the family that might not be able to visit and the medical teams was an important resource for families. Telechaplaincy, could be a way to making those connections. And then when it did come down to rituals, if they were really important, and especially at end of life, that the chaplains were prepared to be part of those sacred moments. Next topic at the beginning of this 2021 was thinking about pain management for patients with severe cancer pain and a history of substance use disorder. So I'll have our poll question with regard to that. So prognosis should be a consideration in whether to prescribe opioid analgesics to a patient with a history of substance use disorder. So 73% of folks thought that, yes, that should be a consideration of whether or not to prescribe opioids. Any of our panelists want to comment on this one, or do you want me to show our conclusions from the Ethics for Lunch?
I'm interested in the conclusions.
Okay. So this is a balancing of, the moral obligations. So knowing that there are pros and cons, harms and benefits when you prescribe. So the beneficence would say, well, person that is having severe pain, you want to achieve adequate pain control for them. When they have a history of substance use disorder, there's this concern about misuse of the opioid or overdose, or even dying as a result of overdose. So not harming the person when you're prescribing it. But also recognition of justice issues, that implicit bias can certainly impact on prescribing patterns and may mean that there's lack of equity in pain control, whether it's actual racism or implicit bias that might influence whether or not a person with a substance use disorder should get opioid analgesics. And one of the points was, well, there can certainly be legitimate reasons to prescribe as long as there are precautions taken and you're working with the patient, working with an interdisciplinary team. And certainly if the cancer is advancing, the length of life, might be decreasing. There's more of an inclination to treat the pain and reduce suffering than worrying about the potential for misuse. Any comments about that one?
Just that, pain management is so much more than the medications. And that's what we've learned over the past 10 to 20 years with the opioid epidemic. So we need to treat pain with a full pain plan that is appropriate to each individual. And that takes into account all of the things that all of their medical history and all of the things that are coming in the future. But their pain should be treated.
And suffering is more than just the physical pain, that there's a whole story to why a person might be suffering, and to address it in all aspects of their life. Great. Yeah. Right, the next one was thinking about trust during the pandemic. And again, thinking about technology. Did the use of technology to allow virtual access to family meetings help to build trust between the healthcare team and family members? Yes, no, or it depends. So here, I gave you the out of it depends, and most people went, or majority of people went with that one, but a pretty even split with yes, it did help to build trust. Any of our, either in the chat, our audience members want to comment of why it depends? And then I'll see if our panelists have any reactions to this.
There are some patients and families that virtual conversations worked really well. There's some setups in the hospital where virtual worked really well for hospitalized patients. And there are others that it really didn't. And I would say continues not to work for, as we are still doing this. And I think that has to be taken into account if you try a virtual meeting and it is not successful either for the patient or family goals, for the health care team goals, or both, then that shouldn't be all. And so moving to the next step and trying again with another format or in person in whatever way can be done is really important, so that communication and those visits are effective and helpful for everyone involved.
Shirley, you had mentioned the greater reliance on virtual visits with family members. Any comment about this in sort of the healthcare setting with family meetings?
Yes, I do. Since we've experienced this, I think there is room to improve upon it. If we, God forbid, we ever get caught up in this, maybe 100 years from now, they would be able to step up their game in being able to connect with families virtually, and it be an acceptable contact with families. But I don't think an in-person, for what we went through, is truly necessary, with the risk to our caregivers, nurses, doctors. I mean, we needed you more than we needed anything in this world to take care of those who were sick, who were in the hospital and to comfort them through this. So I think in the future that we should step up our game into making this a priority of how we're going to access between parents, families, grandparents, children in hospitals, in the medical field. But this is something they need to truly look at and never get caught trying to figure it out again. But I think you guys did a wonderful job. You showed up every day. You walked into that battlefield and walked out of it, whether or not you went back home to your families, whether you had to go to a safe place in order to survive to come back again the next day. I appreciate every moment that you gave.
One of the comments in the chat is, it's still great to have face-to-face conversations if possible, especially if it might be hard to hear news. General updates might be okay to be done virtually, but harder when it's real challenging conversations. And thinking about for the future, as Shirley is mentioning of, how can we really accomplish this? The other comment in here is, did the equipment work? iPads provided for patients, were they able to connect with family members? Did the speakers, were they loud enough? So, could people hear each other, et cetera? We may need to overcome some of those technological hurdles or obstacles.
That was a particular issue inside the biocontainment units. If they are so loud with all the air filtration and negative pressure, and the use of iPads or other things with speakers to communicate specifically with the patients who were in the rooms was very challenging. And I'm not sure if a better solution was developed over time or not, but that was a big issue.
So these are some of the points that were made during that Ethics for Lunch, especially addressing health inequities, where there might be micro or macro aggressions, feelings of racism leading to mistrust, and trying to bridge some of those gaps and build trust. So when it was involving technology, really giving families an opportunity to talk more than being told, making sure that all relevant family members are present, if it is a Zoom meeting or other virtual meeting, getting everyone on board, figuring out the technology to get them to participate, making sure that there's one designated person on the healthcare team to share information and coordinate the communication on hopefully a daily basis, and knowing how important it is to keep the lines of communication open, making sure that's done on a regular basis. That's going to be a way to build trust. Okay, another place where trust might come in is diagnosis of brain death, declaration of death by neurologic criteria. And so we have a couple of questions with regard to that. So should families have the right to refuse brain death examination in a patient with a devastating neurologic injury? Again, pretty evenly split, but majority of people said yes, they should have the right to refuse brain death examination. April, if you want to comment on this one.
From my perspective, brain death is a clinical diagnosis, just as heart failure, diabetes, other neurological injury. And it is important to understand what function a patient does and doesn't have, so that we can appropriately communicate that with their family or healthcare agent, and to be able to make the most appropriate decisions going forward. And without doing the detailed brain death evaluation, we cannot determine if there is any neurological function remaining or not.
So a question for you, April, then. What then does the team do if the family has responded with such resistance to the brain death exam? What's next?
I think part of this is might be in the next question, but it's very important with in any cases where there might be a severe neurological injury that could progress to brain death, of talking early on about what the concerns are in terms of function and progression of the injury. And then once brain death is suspected, or an evaluation is appropriate to do, introducing it as this is the next step in our evaluation. When it is presented as, if it's okay with you, we would like to do this evaluation, then the families then feel that burden. And sometimes then they think they don't want to know. But presenting it as, this is information that we really need to know to move forward, can be very helpful for everyone who's grieving.
And then, as this slide says, using everybody on the interdisciplinary team. So whether it's the chaplain or social worker, patient advocate, various people can help the family process the information and know what the next steps will be.
Yeah, sometimes it's a matter of knowing why they don't want to know.
That is true. Oh, I wanted to answer that one.
I think just in the interest of time, I'm going to move on to this one and just ask one final poll question. True or false, the voices and insights of women and people of color serve as primary sources of expertise in the work of justice? So 100% there. So this was our Schallenberger lecture, Joanne Braxton, a powerful session we had in April. Shirley, did you want to comment on this one?
Yes. It's not that they have expertise in the being discriminated through because of their color. It's that it actually happens. I have 6 children, 3 that are Black and 3 that are white. And I fear for all of them when they leave out of the home. But I fear highly for my children who are Black. I'm a retired police officer. I've seen things that should never have happened. I've intervened in the things that have happened and wondered, why would you do that? I've gone into places and people not knowing me, period, or who I am or what I am, have been discriminated against. And you wonder why. I'm from a multiracial family. We've never had this problem. And it just seems to keep growing, and hopefully it will start to diminish among everybody, because we're all one the same.
Thank you for that. Gonna end this session. I'm gonna ask about next year in a minute, but I wanted to share this poem. Joanne Braxton had put this in a book as a point of reflection about the freedom struggle. So Won't You Celebrate With Me by Lucille Clifton. Won't you celebrate with me what I have shaped into a kind of life? I had no model. Born in Babylon, both non-white and woman, what did I see to be except myself? I made it up here on this bridge, between starshine and clay, my one hand holding tight my other hand. Come celebrate with me that every day something has tried to kill me and has failed. So really thinking about that outrage that Black mothers can feel both for themselves, for their families, and trying to change the world for the better. Last month, we talked about 21st Century Cures Act. Won't go through that today, but in the chat, we've already had one comment of things that you'd like to explore. So if you could put topics that interest you, and then, you know, the other poll question I wanted to ask you is, where should we do Ethics for Lunch come September? So here's the question for you all. Assuming in-person meetings will be permissible, we don't know at this point whether they will be, which of the following formats would you prefer for Ethics for Lunch in the 2021-22 academic year? In-person, by Zoom, combination of in-person and Zoom, or it does not matter? So people like the combination. So we'll have to see if that's technologically feasible. We can explore that, the combination of in-person and Zoom. And anybody wants to share in the chat topics for next year? Thus far, we have pediatric restraints during invasive procedures. If you want to raise your hand and if you wanted to unmute yourself and talk, we're happy to take comments verbally as well. Okay, well, both in combination with the Ethics Committee and with the Berman Institute, and then talking, you know, with you all over the course of the year, we'll generate some topics for Ethics for Lunch for next academic year.